Hi, we're back at the AATS Mitral Valve Conclave 2015. I'm thrilled to be joined by Dr. Thor Sundt. Thor, as many of you know, is Chief of Cardiac Surgery at the Mass General. Nice winter in Boston this year.
That was a memorable one.
Great. So
but the Super Bowl victory made it all worthwhile. So
I noticed this morning that David Adams snuck in the Patriot. I thought, that's kind of cool. So
that's right.
It was very exciting. So, this was originally, and you are debating Ani this afternoon, but I wanted to get your sort of take, because I think this is an important question. So theoretically, a 50-year-old person, we'll make it a 50-year-old, didn't say male or female, 50-year-old who needs a mitral valve replacement, we'll say for rheumatic mitral valve disease. Why would you put in a mechanical valve?
I think that for that case specifically, it's a no-brainer. That person, the odds weigh on are for a mechanical valve. I don't think a mechanical valve is appropriate for everyone who needs a mitral replacement.
Right.
And first and foremost, it needs to be reemphasized that replacement's inferior to repair. We should make an effort to repair, and the guidelines even state it's a class 3 to replace rather than repair someone with degenerative disease unless a repair has been attempted. But in the setting of rheumatic disease, certainly in this country, the availability of anticoagulation clinics and so on and so forth, valve replacement makes sense for a rheumatic. If we repair rheumatics, they're going to come back with progression of the disease. So you're stuck with a replacement. Much older than this patient that you've given me, a reasonable argument can be made for a biological valve. But for that age and younger, if you put in a biological valve, we're incurring the risk of reoperation for sure.
Correct.
The cost of a mechanical valve in someone who's in their 50s is of thromboembolism and bleeding complications. But actually, if you look at the data comparing the long-term outcomes of individuals who are of middle age, let's call us middle age, who get a mechanical or a biological valve, the long-term incidence of bleeding and thromboembolism is actually the same, whether you have a mechanical valve or a biological valve. That's probably due to the onset of atrial fibrillation, so on and so forth, particularly people with rheumatic disease.
Rheumatic disease, correct.
Even if you do a Mays procedure, the Mays procedure is least effective in individuals with rheumatic disease. So it's likely that this 50-year-old male or female is going to end up in AFib. They're going to end up anticoagulated anyway. Why incur the risk of reoperation?
So this was supposed to be a debate, and we've got Dr. Ani came out of the witness protection program, I think, to join us. Thanks for joining us. I appreciate it. So Thor has given us a really great argument about the rationale for mechanical prosthesis in a 50-year-old rheumatic valve disease who needs a mitral valve replacement. What about a tissue valve, a biological valve?
I think a biological valve is an option. But one thing I will say is there are no good options. I mean, both a mechanical and biological valve, they both bring their own problems. The main advantage of a biological valve is for most patients, they don't need to take warfarin, they don't need anticoagulation. Right. And that avoids having to take the medication every day, having regular blood tests, having to worry about the impact of trauma or if you're having medical procedures. And it also avoids complications related to bleeding. That's the main advantage. The second advantage of the biological valve is you avoid the risk of thrombosis of the mechanical valve. The disadvantage, obviously, is a need for reoperation. And the reoperations in the mitral valve, unlike the aortic, carry much higher risk. So the mortality of the two options tends to be the same. The survival tends to be the same because the mechanical valve has its problems with thrombosis and bleeding, the biological with degeneration. So the reason to offer one valve over another seems not to be survival. It's more to do with patient lifestyle and the willingness. Every patient has a different time preference when it comes to risks. So if you're the type of patient that doesn't want to take a long-term risk, like you want to live forever, without any future surgery, then you go for a mechanical valve. But then accepting that from day one, you face the risk of bleeding, thrombosis, and so on.
I deal with patients all the time, and they say, "Gee, when you mention the word stroke, I don't want to have a stroke." So and by the way, doctor, if you put in that biological or tissue valve, aren't you going to be able to put another valve inside that if this valve fails? So what about that?
It has to be clear that there's a risk of stroke with every valve. So as Dr. Sundt has said already, patients even with a tissue valve can develop atrial fibrillation, and indeed up to a quarter of them, if they don't have it, will develop it during follow-up. So they will need anticoagulation, and they do face a stroke risk. But the risk of stroke in the long term seems to be about double with a mechanical valve compared to a tissue valve. As regards the second question about the possibility of a valve-in-valve, in future, that's likely to become the dominant means of treating structural valve degeneration. But I must say that we have to be aware that based on current data, it's still a very high-risk procedure. About 10% of patients still don't survive the first 3 months after the procedure. It might be to do with patient selection, but it doesn't come for free. And the second thing is we don't know the long term. And we have to also realize that in looking at the outcomes, only patients who get treated get included in studies of valve-in-valve. But for each patient that gets a valve-in-valve, there are some patients who got structural degeneration that might not have survived to get a valve-in-valve or were not candidates. So I wouldn't regard that alone as the solution in saying that biological valve is better. So I think if you are taking a biological valve, you have to be aware that the valve will fail in your lifetime if you live long enough. And when it fails, you will face a high-risk reintervention.
I agree with those points. As you said, you could argue either side. I mean, it's interesting though, because I think to the young cardiologists, they're not thinking mechanical valves. They're thinking biological valves. I think your point about atrial fib being, and people with rheumatic disease, they've got a diseased atrium. So even if you do a maze, as you said, so I think you're making a strong case. Both of you are that a mechanical might not be that bad of an option. I hate to say it that way.
I think,
and a 50-year-old.
I think my sense is that, and full disclosure, as Ani and I said, we could argue so we could have swapped topics. And I think most of us these days tend to be tissue-oriented in most of our replacement and reconstructive options. But mechanical valves shouldn't get the short end of the stick here. They're actually are very good devices. I mean, they're remarkable devices, and they have a very good track record. And for the right patient, it's a good option still.
I had an interesting discussion this morning with Tuisak from Bangkok and Manuel Antunes, and talk about rheumatic disease and everything. So on the rheumatic theme, are we as proficient in this country in doing mitral valve repairs and rheumatics as they are? You all obviously do.
Certainly, for most reference mitral centers, they can do good rheumatic repairs. But I think where we differ from Asia is in the patients that actually present and the stage in the disease they present. So in Thailand, which you mentioned, most of the patients are presenting in childhood, adolescence, or young adulthood at an earlier stage in rheumatic disease. And if the leaflets have some pliability, you can repair them. And certainly in a younger patient, that would be, in my center, our default is to repair.
I agree with what Ani said. The vast majority of rheumatics, by the time they get to the operating room, Igor Palacios has already done balloon valvuloplasty 2 or 3 times, and by now they're very scarred down. Yeah.
Well, you guys have done a great job, and I know you're gonna have a chance to redo this debate later on today. But thank you both for taking time to visit with us. Thanks very much.
Thank you.